So I am pleased to introduce my colleague, Michaela Jackson, who is the Program Director for Prevention Policy here at the Foundation. In this role, she leads our national policy and advocacy initiatives to strengthen hepatitis B prevention, expand vaccination and screening programs, and promote equitable access to care. I think many of you have seen her recently as we tackle all things ACIP related. But she's an inspiration to me and the rest of my colleagues for her dedication on this topic, and I am excited to turn it over to Michaela.
Thanks so much, Frank. Hi, everyone. Thank you so much for attending our summit today. Very excited to be here and very excited to have the speakers that we have on the panel. So today we're talking about hepatitis B, but not just in the realm of, as Frank mentioned, the ACIP conversations, but across the lifespan, since that is something that all of us have been working on. And we definitely don't want to lose the progress that we have made thus far. So I'm really excited to continue those conversations today. Next slide, please. So very briefly, I just wanted to go over a kind of current state of hepatitis B vaccination in the US. Lots has changed over this past year. Very many things are confusing. So I hope this provides a little bit of clarity before we go into the presentations. But as many of you know, the birth dose is currently being questioned. More specifically, its necessity and the universal nature of the birth dose is being questioned on the federal level. And there's a very high risk for its removal, for the universal recommendation to be removed. And what this means essentially is it's going to shift us back to a risk-based vaccination for babies. We've tried this in the past. It did not work. And this has far-reaching impacts, although it might seem small. It definitely has impacts on insurance access. It has impacts for the supply chain of hepatitis B, but also for mothers and parents living with hepatitis B. And I will flag right now, one of the things that we are hearing more and more often, unfortunately, is that mothers who are living with hepatitis B and who are pregnant are coming into providers' offices right now, and they are either rejecting the birth dose for their child or questioning it. So even though we're talking about keeping a recommendation for mothers at risk, they're hearing the same concerns that others are hearing around its safety, which we know it is safe, but they're hearing those questions and they're having their own questions. Right now, we do have the childhood vaccine recommendation, which is a universal catch-up program through 19 years of age. And this could potentially be in jeopardy. We don't know yet, but ACIP has developed a new childhood and adolescent immunization schedule work group, which technically the hepatitis B vaccine would fall under as well. And the adult vaccination, we do have universal now, as many of you guys know, and thank you so much for your advocacy towards that. This has not been touched by ACIP, it hasn't been questioned by ACIP yet, but we have concerns because universal recommendations in the current climate can be seen as mandates by some, especially after COVID. And it's been a little bit slow and difficult to implement. So we have speakers today who can hopefully help us overcome some of those challenges. And next slide, please. I just wanted to highlight very quickly for you all. You guys have already received emails and we'll get more, but we do have a town hall coming up on ACIP. So any questions that you have around hepatitis B conversation birth dose on federal level, please do join us. And with that, I'm actually going to get into our speaker bios for today's presentation. So we're kicking it off with Charlotte Moser, who works as the co-director for the Vaccine Education Center at the Children's Hospital Philadelphia. Charlotte created the Parents Pack program for parents and the public and co-created the Vaccine Update program for healthcare providers. She has also helped to integrate the Vaccine Makers Project, an outreach project for classrooms, into a Vaccine Education Center-based program. Charlotte was the consumer representative on the CDC's Advisory Committee on Immunization Practices until the entire committee was dismissed on June 9th, 2025. That presentation will be followed by Dr. Nina Kim. She is a professor of medicine at the Division of Allergy and Infectious Diseases and an adjunct professor of health systems and population at the University of Washington. She works at the liver clinic at Harborview Medical Center, Seattle's largest safety net hospital, and conducts and mentors trainees on health services research using electronic health records. She also serves as the associate editor of Hepatitis B and Hepatitis C Online. And our final presentation will be by Syreeta Wilkins, and she is a senior technical consultant with the Migration Health Initiative at the Task Force for Global Health, which is previously known as the National Resource Center for Refugees, Immigrants, and Migrants. At MHI, Syreeta directs the health promotion efforts, serves as the technical lead for human-centered design initiatives, and leads the dissemination strategy for MHI resources. She has expertise in language justice, health promotion, and engaging with diverse and multilingual communities. And with that, I am happy to turn it over to Charlotte.
Thanks, Michaela. I guess, great. Thank you, Frank. So you can go to the next slide. Today, we're going to be talking about overcoming hesitancy around the birth dose because of the timeliness of the topic. And when people are wondering whether they should vaccinate or not, there are really a couple of things that go into their decision. It's not only what they know about the vaccine or the disease, but also their attitudes. And that means that our discussions and our health messages need to take both of those into account. Next slide, please. So when we're thinking about attitudes, next slide, there's a theory called social judgment theory that I think can help people to think about how somebody's attitudes might make a difference. And this theory was developed by Sharif and Hovland in the early to mid 1960s. And they said basically that everybody has an existing attitude structure about any topic. In our case today, we're thinking about, vaccinations and hepatitis B in specific. But when they hear incoming messages related to that topic, whether or not they're going to have a change of attitude is based on how the message fits into this existing attitude structure. Next slide. There we go. So when people are asking, are vaccines safe, what they're really asking or thinking about is what is the risk? What is the risk to them or their infant, whoever it is that's going to be getting vaccinated? And we tend to use safety and risk as interchangeable ideas, but they actually are not interchangeable because risk is something that can change over time or by situation, and it varies across people. And on the next slide, I'll show you a nice example of, you can go to the next slide, of offered by McPherson. It doesn't have to do with vaccines, but I think it helps us to think about safety versus risk. So if we wanted to know which of these two bridges were safer, we could send the engineers out and they would go take a whole bunch of measurements, write up a report, and chances are the report would tell us that in comparison, the bridge on the bottom is safer than the bridge on the top. And we would have those data to look at both bridges' relative safety. Next slide, please. But if these two friends are walking through the woods, they're going to be thinking about which bridge they would prefer to cross based on which one they think is less risky. And chances are they too would choose the bottom bridge, thinking that it looks safer, it's less risky. But on the next slide, if we see this guy coming towards us and we're walking in the woods, chances are we're going to take whichever bridge is closest, even if it's the top bridge that looks a little bit more dilapidated. Next slide, please. So what that example shows us then is that risk is subjective, but safety is not, because those two bridges would not change in terms of what's written in the report about them that's sitting on somebody's desk in their office. What changed were the scenarios, how people felt about their risk in that moment. Next slide. And when somebody thinks that something is risky, as Thompson described, it gets moved into the deliberative realm and singled out for scrutiny. So in the current environment where we're thinking about vaccines or talking about vaccines, one can anticipate that many parents today feel like they need to scrutinize vaccines because vaccines are generally being discussed as being risky. And that scrutiny is going to result in questions. And I think where sometimes we take it a step too far is that when people have questions, we think that means they're being hesitant. But I would argue that they're just doing their due diligence a lot of times. Most people want to be able to accept vaccines. They just think they need to be checking them because the environment is telling them that it's risky, that vaccines are risky. Next slide, please. Now that brings us to the other part of this equation, the knowledge. Next slide. So when we're thinking about hepatitis B virus, what people commonly know or think of when they hear about hepatitis B is that it's a sexually transmitted infection and that it's spread by injection drug use. And based on this, some people then draw the conclusion that only babies and children of women with certain backgrounds are at risk, and therefore the birth dose isn't necessary. Now, I suspect everyone on this call agrees with me that this really doesn't provide us with a complete picture of evaluating risk related to hepatitis B virus. Next slide, please. Because probably, again, you all know everything on this slide, but let's just quickly go through it. Hep B virus hides in plain sight. And if we start at the bottom of the triangle in the middle, we know that this virus can live on surfaces for several days. We know that it can be spread through quantities of blood that are too small to be seen with the naked eye. In the middle of that triangle, we know that about half of the people in the United States who have chronic hepatitis B infections don't even realize they're infected. And at the top of that, we know that when kids are exposed to this virus, they're less likely to have symptoms and they're more likely to develop chronic infection. So when we take all of this together, looking at the last triangle on this slide, then we know that people can not only unwittingly be infected with the virus, but they can also unwittingly spread the virus. And this is why people need more information to be able to appropriately frame the risk associated around this virus. Next slide, please. So in sum, vaccine decisions rely on both attitudes and knowledge. People have predetermined attitude structures about vaccines. Risk and safety are not the same. Even if people are using the word safety, they're thinking about risk. Risk means thinking about scrutinizing the topic, and questions sometimes are the result of that scrutiny. And when we think about hepatitis B virus, we need to be answering questions and helping people adequately frame their risk by understanding more about this virus than what is commonly known by most people in the public. Next slide. And so I'm going to stop there, and you can see a bunch of the websites that the Vaccine Education Center offers information on. And I look forward to sharing in the discussion in a few minutes. Thank you.
Hi, everyone. Very happy to be here today. I'm going to be giving you basically 5 strategies, 5 minutes, a rapid review of evidence-based strategies to optimize Hep B vaccine uptake in your system. So in medicine, we like to use acronyms and mnemonics to help us remember concepts. So today I'm going to use the word boost as kind of a playful nod to vaccination to walk through the different strategies that health systems and local Hep B champions can use to optimize vaccine uptake. So the first letter B is for barriers or bottlenecks. And here I'm really referring to operational roadblocks. So there are a multitude of reasons why Hep B immunization may not be optimized in your setting. And I would say here that, using kind of QI science and QI principles, get curious, talk to your frontline workers, your teams, explore what might be getting in the way. I've included a handful of examples that are certainly not exhaustive, but I will say that coverage of Hep B immunization has not always been consistently broad or consistent, as an example, and clinics face a complicated and sometimes inconsistent process for billing third-party payers for immunizations. And in some cases, reimbursement rates have historically been so low that they do not cover the cost of vaccine, while other payers might not cover it all. And therefore, you can see these missed chances to immunize patients, especially given the confusion over insurance coverage and administrative obstacles. And I think these concerns about costs can also trickle down and contribute to patient vaccine hesitancy. But I will say that there have been policy changes as recently as this year that have made Hep B immunization a priority. Medicare, for example, used to cover Hep B vaccine only if a provider ordered it and if the patient was considered intermediate or high risk. This is based on the old CDC criteria. But in 2025, these requirements are now gone. Medicare covers the Hep B vaccine for all eligible individuals, including those who've never received the vaccine or whose history is not known. And Hep B vaccine is now paid like other preventive vaccines and not subject to deductibles or co-payments. Rural clinics and federal qualified health centers can now receive real-time payment for these services, which of course improve cash flow and make the vaccine delivery a more viable financial option. So I wanted to make sure everyone knew that because this is a change that happened essentially this year. So O stands for orders, or more specifically, standing orders. And so standing orders emerged as a strategy to improve immunization coverage by enabling non-physician staff, like nurses and pharmacists, to vaccinate patients according to an institution or physician-approved protocol. And this task shifting is really a critical piece of effective and widespread delivery. The main goal is to really just make it easier to give vaccines by eliminating this sort of bottleneck of having a separate physician visit or signature for each dose, electronic signature as were, and essentially, which created essentially a barrier for timely administration. There are a number of example templates or protocols available at immunize.org, which I would encourage those of you who are not sure where to start to explore. And I think this is where using the electronic health record to its full potential can be done by integrating standing orders of the full Hep B vaccine series, as well as prompts for different members of the team. And on that subject, the electronic health record can provide a variety of opportunities to improve Hep B immunization in your system. A group of us created and published a practical guideline, or really guidance, I would say, for how to go about this, including how to incorporate screening and immunization together in the same encounter, which I think is something that has kind of stymied providers. They're not quite sure what to do and how to do it. And I think there are ways you can provide guideposts in the course of the EHR framework to do this. The second O is for outreach. And as Zinnia illustrated through their NIMS program, nudges to patients do work. And there's good literature explaining this through other kinds of immunizations. And I would imagine Hep B vaccine falls into this. So patient reminders and recall systems have been shown to increase vaccination rates across different populations. And again, you can use automated systems to save time and resources in that regard. And the modality may differ depending on the patient population you're looking at. It might be a telephone outreach or text or electronic health record. So this is an example this is a screenshot of the MyChart portal that Epic uses. And they have this health reminders feature with this nagging little red button here that shows patients that they're due for as far as preventive health screenings and vaccinations. And actually, I will tell you as a provider that this has definitely been helpful in engaging people in their own care. And I have patients who remind me when their vaccines are due. So yeah, when it comes to outreach, I think there have been a few different things we have learned from the literature. One is a sort of a gentle presumptive approach, framing vaccine recommendations as a standard part of care, saying, it's time for your Hep B vaccine, simplifying and personalizing the message and providing clear, direct advice that's tailored to the individual's needs and health status. So the S is for settings, and here I'm talking about the idea of diversifying settings where vaccines are offered, and as well as integrating vaccine services in other forms of healthcare. So this might mean expanding access beyond traditional clinics. I put down a number of different examples where immunization might occur. Or it might mean integrating vaccination within existing health programs that can improve efficiency and greater opportunities for patient vaccine completion and follow through. As an example, in our UW medicine system, a variety of clinics are capable of providing Hep B vaccines. It's not just the primary care clinic. And so I think as a Hep B champion, you can envision connecting with different existing screening and treatment programs, particularly those outside the community, outside your own institution, out in the community, that could potentially incorporate this aspect of care. And then finally, T stands for training, which is, I actually think uncertainty and lack of confidence about Hep B can be a major contributor to gaps in practice. We have a web-based curriculum called Hepatitis B Online that's supported by the CDC that offers a variety of different learning opportunities with free continuing education credits. And we have a new third edition coming out very soon. I've highlighted our lesson on Hep B immunization. We're also the site that hosts the simplified Hep B guidance that Zinnia mentioned, and we will also be posting the updated version of this as well. And we've got a mini lecture on top 5 questions on Hep B immunization, and that's it for me.
All right, I'm trying to get my screen shared.
Hi, everyone. My name is Syreeta Wilkins, and I am a senior technical consultant with the Task Force for Global Health, and I'm here to talk to you about hepatitis B vaccine promotion among immigrant and refugee communities. Next slide. So, I work for the Migration Health Initiative, as I said, at the Task Force for Global Health. You may have recognized us by our previous name, which is the National Resource Center for Refugees, Immigrants, and Migrants. We've worked with CDC, especially the Department of Global Migration Health, since about 2020. And the current funds for this project came from NCIRD. Next slide. So basically, at the Migration Health Initiative, our mission is to support the health for people experiencing migration through partnerships, collaboration, and community-driven solutions. So we're not only focused on hepatitis B, but that's what we've been working on primarily over the last year. Next slide. So what I'm going to talk to you about today is largely related to the Protect Your Family campaign, which is a campaign that we created to promote hepatitis B vaccine uptake in immigrant and refugee communities. Next slide. And so to create this campaign, we use a community-informed approach in order to prioritize the perspectives, the values, and the expertise of community leaders. So we worked with 9 community leaders across the United States who together represented 10 countries and 11 languages across sub-Saharan Africa and certain countries in Asia. And I just, thank you, next slide. So I want to talk to you about a few things that we learned from them. And the first is in creating a campaign, in terms of color and format, people preferred our blue and teal branding over styles that were more obviously culturally specific. So the sub-Saharan African folks quickly rejected the version of the fact sheet that used Pan-African colors and wanted something more neutral. Next slide. So leaders wanted to see themselves represented in the images, but they didn't want to see exclusively themselves. And so they felt like showing only one community would lead people to believe the community was responsible for hepatitis B. So they advocated for really diverse representation. Next slide. They wanted to see photos of people they could relate to. That everyone really loved this soccer image, to think like this young, healthy looking soccer player could have hepatitis B, so could I. They really preferred that over kind of the faceless illustration style. And having photos rather than images is more challenging for us, but we took the time to invest in it because we felt like it would be sort of worth it to create a more resonant campaign. And actually, when we did this testing, several of the community leaders pointed photos out and saying, that person's not African immigrant, they're African American. And so I actually sourced a lot of the stock images from photographers that are based in different countries in sub-Saharan Africa in order to account for that. Next slide. We learned that folks wanted to see photos that were suggestive of medical procedures, but that didn't show blood or needles. So on the left, you see a photo of somebody just after they got their vaccine, and on the right, you see someone just before they get their blood draw. And so they told us, don't show needles or blood, show these other images instead. Next slide. So our materials were rigorously translated in 16 languages, and we analyzed a number of factors when deciding what languages to translate into, including immigration patterns to the US, hepatitis B, vaccine uptake in home countries and chronic hepatitis B incidence in home countries. And we also looked at the availability of materials from other organizations like Hep B United, a hepatitis B foundation, like the CDC and other places, to figure out what kind of gaps we could fill. And that's, just as an example, people from Vietnam are disproportionately affected by hepatitis B, but there's already a lot of resources out there in Vietnamese. So even the ones that you see in bold here, those are languages where we couldn't find any products, and so we wanted to be sure that we prioritize those. Next slide. Now, we want anyone to be able to customize our materials without design software or expertise, so we have drag and drop templates in Google Slides and Canva paired with a stock photo library, so anyone can adapt our materials to meet their community's needs. Next slide. Community leaders also told us that if we want to reach people across generations, we needed to invest in multiple formats. So our materials are available in print, digital, and audio-visual formats to meet this need. Next slide. And finally, each print material contains a QR code that directs people to a video that has the same content. And that way we can meet the needs of people who prefer to read as well as those with a more oral tradition. Next slide. And I have a lot more to say and show you, but I want to make sure there's time for questions. So I put a QR code here in case anyone wants to download the campaign, and I'll also put a link in the chat.